because if nothing is done about it, you can develop infection, you can develop kidney damage, and most of all, it's just a nuisance. And many men will have acute obstruction where they simply can't urinate at all. And that's where, in some cases, acute treatment is needed. Now, the standard treatment for prostate obstruction is what's called a TURP. We call it a TURP, the rotor-rooter job. We have this device that goes in and cuts out that prostate tissue. And that's a standard way this has been treated for years. In fact, it was the only treatment for many years. But let's go back. A couple of years ago, some new medications came on the market that do two things. There's a medication that allows the outlet of the bladder to relax. That's called Hytrin. The drug is called Hytrin. And there's another medication on the market that causes the prostate to shrink. And that's the medication called Proscar, which is the medication that you saw the ad for. Now, how do these medications work? Well, Hytrin works by relaxing the muscle at the outlet of the bladder and allowing this channel to open up because the muscle is more or less paralyzed, so that it just passively allows the urine to flow through better. Proscar works because it blocks the effect of the male hormone on the prostate. And if you deprive the gland of the male hormone, theoretically it should start to shrink. And in fact, it can do that if the condition hasn't been allowed to progress too far. If the gland has gotten too big or the damage to the bladder has gotten too great, then these medications don't work, and you still then may require some kind of surgery to open up the gland. Now, fortunately, there are some new techniques in that respect as well. I think the day will come when only a small percentage of people will need this more complicated surgery that cuts out the prostate gland. We now have some laser techniques that will allow this tissue to be vaporized with a laser. The laser technique is expensive. The recovery from it is relatively slow. And the newest thing on the market is a electrovaporization of the prostate. This is a device produced by an American company that with an electrical current causes the gland to simply vaporize.
You are watching the DADS television network. We're focusing on men's health. If you'd like to contact us, in Portland, area code 503-222-1111. In Seattle, area code 206-623, DADS, that's 3237. And in Albuquerque, area code 505-299-2673. We would like to hear from you at P.O. Box 8525, Portland, Oregon 97207. Back to the program, and Dr. Warren Farrell, author of The Myth of Male Power.
Why our dads are about as equally as likely to die of prostate cancers as our mothers are of breast cancer, while breast cancer receives 666% more funding. So you have the same number of deaths from prostate cancer as breast cancer.
14% fewer deaths from prostate cancer as from breast cancer, but 660% more funding before Hillary Clinton got involved in the process of supporting breast cancer funding. And so I am very strongly supportive of breast cancer research and funding. I also want us to, to help prevent the Frank Zappas and the Bixbys that die of prostate cancer.
You're going to go through this at the White House tomorrow?
As much as I can get through.
Are you going to say that there's a Women's Office of Health?
I'm saying that there is a Women's Office of Health in the NIH.
Yeah.
There either needs to be a Men's Office of Health in the NIH.
Why?
Because 10% of the funding is focused on women's health, but only 5% on men's health.
All right, on the 15 leading causes of death, who die earlier?
In the 15 leading causes of death, men die earlier from all 15 leading causes of death.
Is there an Office of Men's Health?
There is no Office of Men's Health.
Now listen to the words of Dr. John Bonham from Atlanta, Georgia, a man who speaks with wisdom.
Okay, my name is Dr. John Bonham. I'm from Atlanta, Georgia. In NCMC, I'm on the Men's Health Committee. and I'm also president of an organization called the National Black Men's Health Network. My primary interest is men's health, the reason being that in the United States, life expectancy for men is approximately 7 years, less than that for women, but there's very little specific attention to men's health. Men have a lot of disease of the reproductive system. Women have a whole specialty of medicine devoted to their health concerns in terms of reproduction, reproductive disease, reproductive cancers, but nothing comparable exists for men at this time. Men have rates of prostate cancer which rival women's rates of breast cancer. Approximately 1 in 11 men in the United States are expected to develop prostate cancer. Cancer of the testicle is the leading killer of men aged from 28 to 34. And yet very few men know anything about it or know about that issue of their health. My own father almost died in 1988 because he didn't know about a condition called prostatic hypertrophy. The majority of men, if they live long enough, will develop enlargements of the prostate leading to urinary difficulties. My father's symptoms were that he was having difficulty urinating and then he was developing blood in his urine, but because he knew nothing about prostatic hypertrophy, he thought that he had an infection and he kept taking antibiotics trying to make it go away. By the time he got to the hospital, he had lost so much blood that he needed to have blood transfusions because he was ignorant of this problem. Yet it is a problem that the majority of men will develop and don't know that. So issues of men's reproductive health have been seriously ignored in the society, even though they are a significant cause of mortality and morbidity. One of the problems men have in health care is that we've been taught specifically to ignore the signals of pain, what our body is telling us. We've been taught that when we're hurting, to keep on going, to soldier it, to not pay too much attention to it. But pain is part of your body's natural warning system to tell you that something is wrong. When a person is told when they're young that big boys don't cry, when they get older and they're having chest pain, they tend to write it off as something like indigestion, and it can be a symptom of much more serious problems such as coronary artery disease. So men need to be told that when they are feeling pain, when they are feeling discomfort, this is a signal that something is wrong, that they have a right to address it, that they have a right to health care. These are the type of issues that we're trying to address in the Men's Health Committee. These are the type of things that we're hoping to change. A lot of the difference in life expectancy between men and women, even at our present level of technology, is not necessary. A lot of it is caused by the expectations of society, and this is what we're trying to define and delineate.
The DADS television network once did a program on artificial insemination and sperm banks. Here's a review of that program.
Now, at her microscope, what does she do?
Just counting sperm, probably. Counting the number of sperm in a sample.
What's the norm? What's a good count? What's a poor count?
Good count is any above 20 million per mil.
Okay.
20 million per, like a teaspoon.
And Okay, and anything below 20 million is...
Well, it's arbitrarily, it's a threshold, an arbitrary threshold that we use for normal versus abnormal. For sperm banking, we would expect that cutoff to be more like 50 million rather than 20.
Okay.
But if you're talking about infertility embryology that we do to support the in vitro fertilization program, we would prepare sperm here, and then the laboratories for the embryology upstairs, so we can go upstairs and look at it if you'd like.
Okay, as we rapidly progress to what we're getting at here, we have as our guest Dr. Don Wolf. Dr. Wolf works for the Oregon Health Sciences University, and he works in the university fertility area. Is that right? Or you're a consultant?
No, the Division of Reproductive Endocrinology and Infertility is called the University Consultants.
Okay.
It's a group of physicians, and in this particular case with a laboratory director, myself, who work together at the River Place facility.
Okay. Now see there, we're learning something already. I've looked through some of the material here, and it says, Doctor, that the primary concern here is, or they use a couple of words quite frequently, andrology and embryology.
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 Right.
Okay. Andrology, if I know my words right, has something to do with the study of man. Is that right?
Yes, it's basically, in this particular case, it's the diagnosis and treatment of male infertility.
Okay.
Or fertility, depending on how you want to look at it.
And then the other word slash
Embryology?
Embryology.
Well, that's going to refer to the technology of in vitro fertilization, where we're actually taking sperm and eggs and producing embryos.
Okay.
So the development, the early development, is called embryology.
All right. Now, you're the director there?
I'm the director of the laboratory component. Right.
Okay. How many components are there?
Well, there's a component in which physicians consult and see patients and manage patients. And then there's a laboratory which provides the services to those patients and their physicians. So we would do the diagnostic testing of sperm to try and evaluate the fertility potential of a given individual. We would be involved in getting sperm and eggs together to produce embryos.
Okay.
So.
Okay. So that, and you're in charge of the lab part of that.
That's right.
The other section where you would have an attending physician, I suppose, attend to the client who comes in the door. Well, he's also a consultant, is he not?
He or she, yes,
Okay.
yes.
Do you have?
I mean, they're really in a situation where they need to diagnose the nature of the problem.
Okay.
Is it male-based? Is it female-based? Or is it both? To try and put together a plan of action to treat the particular situation that they're faced with.
Now, this goes to a little bit of an opening remark to introduce the doctor and to let you know generally what we're doing. Now we're going to get a little bit further into this, and again, I hope the numbers flashed on the screen because we do want to entertain your calls. This is designed, this particular program is designed for you to ask questions.
Hi.
Do you have a question of Dr. Wolf?
Yes, actually I do. I'm a patient of another clinic in town here in Portland, and I'm familiar with the OHSU sperm bank as compared to the one that I'm currently using, which is the California Cryobank, which is much more, to me it's more expensive because I have to have the specimens shipped.
Well, just a second, which is much more expensive?
California Cryobank is because I have to have them shipped.
Okay.
I have a question for Dr. Wolf, though. Regarding the OHSU bank, I would be interested in using that because of the cost and the proximity, except that it is my understanding that they do not give as much information about the donors, where the California Cryobank will go back for 3 generations, and the OHSU gives very general descriptions of donors. Can you tell me anything about that?
We screen our donors, and we in fact determine a medical history and determine their acceptability or their ability to participate in the program depended upon having essentially no significant medical problems over 3 generations. But we don't provide that information to the users of